welcome again to another edition of JewishSacredAging.com and Jewish Sacred Aging's video conversations. We're very happy that you joined us, and we have a very special guest on this edition of Jewish Sacred Aging Video Conversations, and we'd like to welcome Dr. Stephen Goldfine, the Chief Medical Officer of Samaritan Healthcare Hospice here in Southern New Jersey. Welcome to Jewish Sacred Aging, Dr. Goldfine. Thank you for giving us your time to talk about something very, very powerful and very, very exciting and very, very important.
Thanks for having me. I really appreciate being here.
So let's start with the basics. There's a lot of conversation now as end-of-life conversations continue to gain momentum, legislation around the country about some of this stuff. More and more people, baby boomers, are involved in these conversations with parents. And what exactly is hospice?
So hospice really is a benefit from Medicare and other insurance companies that provides support and care in the last 6 months of your life. What you get from a hospice program is you get a physician that comes and helps to manage your symptoms, a nurse who is an expert in end-of-life care, symptom management, social worker, home health aide, some equipment, as well as some medications to help ease your life. The goal of hospice really is comfort. It's not really about death, but it's about living your life as comfortably as you can for whatever time you have left.
Yeah, I think that's a very important conversation to have. And if you could just talk a little bit about that. There seems to be a perception when one hears the word hospice that it's just about death. But really, from what you're telling us, it's really about life, correct?
And I think really it's important that we focus on the goals of the patient. You know, what's important to that patient, what brings really quality to their life. You know, I don't really know how long somebody has to live. You know, I think that's really the hardest part for physicians. We're not very good at prognosis. But what we do know is that if your life is short, you might as well live each day as best you possibly can. Unfortunately, when you're being treated aggressively back and forth to the hospital, doctor's offices, you're not focusing on what is important to you. So, for example, a lot of our patients, we help them get to the shore for a day. One woman recently just got to do a horse and carriage ride, which she had never done in her life. So really focus on those really quality life, things that really are important to you.
You mentioned the Medicare thing. Let's deal with this right away. Sure. Because if there's one thing that many of us don't understand, it's this whole insurance thing. You alluded to the fact that Medicare coverage, does Medicare cover the entire hospice? When somebody enters hospice care, does Medicare cover all of that?
So it really does, but it covers things related to the disease process. So for example, medications, the nursing staff, home health aide, the chaplain. So we'll cover those things. Unfortunately, with hospice, it's not around-the-clock care at home. It's only really episodic care at home to help the family support the patient at home. So the nurse may come out to the house 1 or 2 times a week, depending upon the severity of illness, maybe actually more if somebody's actively in that dying process or needs more support. Home health may come out for an hour or 2 a day, a couple times a week. So really, it's about having that family support the goals of care for that patient.
So if a family has somebody at home and they're under the hospice care and they feel that they need 24/7 live-in home health aides, that's a separate expense. Is that correct?
There'll be a private pay expense, exactly.
Okay. So you talk about that there's a conversation a lot about hospice and the 6-month window. What does that mean and how firm is that?
So, as I said before, doctors are not very good at prognosis. We miss most of the time. You know, we're certainly we don't have a crystal ball to read the future. When you look at the Medicare benefit, it says 6 months or less if your disease progresses as expected. And I think that's really the important phrase there. So if you have Alzheimer's disease, for example, and you've stopped eating, you may live for a week or 2 or 3, but I've seen patients live for honestly months and months and months. Right. If you come up to that 6-month window and you're still declining, things are still progressing, your disease is getting worse, then we can extend the benefit for additional benefit periods over time. Unfortunately, if you stabilize and your symptoms are no longer happening and you're not declining, then we do have to take off the program. But really, it's in the hospices and the physicians' right to determine who gets to stay on the program.
So you mentioned about home, and I know there's some hospice groups that are freestanding, yep, and there are some that do hospice care in somebody's home. Samaritan does both, or what's the difference, and how does one qualify for one or the other, and what's the story with that?
So Samaritan actually all hospices have 4 levels of care, of hospice care. So we have home care, which is about 99% of our patients. There's something called respite care. So if you're on the program and your family's been taking care of you for months at a time, and they need a little bit of a break, you can go to a rehab facility, nursing home, to get a 5-day respite stay, which I think is a benefit for the family, because if this is difficult for families, and we want to make sure that they have a bit to recharge themselves, re-energize themselves. Something called inpatient hospice, and Samaritan does have a unit in Mount Holly, New Jersey. We're actually building a freestanding unit in Voorhees, which we're very excited about. To qualify for an inpatient hospice stay, you need to have symptoms that cannot be managed in another environment. And we interpret that as being the need for intravenous or IV medications. So your symptoms are so out of control, that your pain is so severe, your breathing is so short, that you need IV medications like morphine or Ativan to control those symptoms.
So you mentioned these 4 steps, and this is common to all hospice associations all over the country.
It is, yes.
You mentioned the family thing, and as clergy, all of us deal. It's not only the individual, but this is a family systems issue. So walk me through a little bit how not only Samaritan, but a normal, typical hospice, if somebody's contemplating this or thinks that this is in their future, what is the support network that a hospice will provide for the spouse, for the adult children? We've all of us have dealt with situations, not only the adult children, but grandchildren.
Absolutely.
Who have these very close relationships. And as a follow-up to that, how do you begin to deal with when there's distances, long distance situations? I'm sure you'll get a call from somebody, the adult child living in California, saying, what's going on here? I just found out that mom is going into hospice care. What do I need? How soon do I have to get on a plane?
So a lot of it is about communication. And I think that's really what separates hospice from all other medicine that's happening in this country right now. We're very proud of how we communicate with our families, keeping them in the loop of that case of that patient. We focus on communication and really trying to have the right communication at the right time. It is important that we focus on the patient. The patient is always the center of care for us. But I often get involved with families that are just upset, that don't understand what's actually happening. I spend a lot of time just sitting down and trying to understand their fears, their anxiety, what they're thinking about. And it's really as simple as asking the question, how are you doing today? What's going on with you? I'm always surprised when I walk into a room and I turn to the daughter when I'm walking out the door and say, do you have any questions for me? Or how are you doing today? And we get that response. So we try to be present within that. The beauty of hospice actually is not the medicine per se, but it's all the counseling that goes along with the hospice. Social work, so the social workers, their job is to counsel, not to just do placement type of things. They'll spend hours counseling the patients. Bereavement, I think, is something that's very, very important. Nowhere in medicine do you get bereavement services paid for. In hospice care, you get 13 months of bereavement after the patient passes away.
I think most people aren't even aware of that. Walk us through, what does that mean?
So at Samaritan, at least, what we've decided to do is that it's not just enough to send a card or make a phone call, but we need to actually connect with those families. We try our best to connect with the families afterwards and make sure that the families are coming in and talk to our bereavement counselors. Our counselors go to them and they do some sessions with the families. This is really important with children, because children of all ages feel the loss as severe as we do as adults, but can't express it always. So to have the bereavement counselor meet with the child and then spend some time doing some play or doing some coloring, I think is really important for that.
Do you ever get people who just say, I don't want it?
Unfortunately, all the time. They don't understand. I think that back to hospice, I think one of the things that's not taken advantage of is that bereavement services. We do a lot of free kind of group sessions, and I would love to see them more attended. I'd love to see that our patients and our families get there. I think a lot of it is patients don't always understand the bereavement needs, and oftentimes it happens well after the patient passes away. Right. So in that first couple of weeks after somebody passes away, it's all that trying to deal with the estate and deal with the funeral. It's all the details of that. A month later, when that that loss is there, is when the family actually needs the bereavement. And that's when we reach out again to make sure that we get them on that second kind of time frame.
I want to go just to explore something, because I know Samaritan is involved heavily with the program about going to the front end of this process, the real front end of this process, before even illness happens, and encouraging families to have a conversation about the what if. to develop a real care plan, a family care plan, an advance directive, how healthcare proxies, something called a pulse, which is a physician's order for life-sustaining treatment. Mm-hmm. So I want you to explain, if you can, how important is it for a family to really now, in this day and age, given the spread of medical technology, to really sit down when everybody's healthy and develop that care plan?
I think it's invaluable. I think that a lot of times we get involved with a lot of technology medicine. They can do a lot of things. And the question is, should we be doing these things to these patients? What happens in a crisis is we tend to do everything. Yeah. And that patient may not have an outcome that is actually appropriate for that patient. We've been working with our palliative care program, and our palliative care program is a program we developed about 5-6 years ago. Palliative care is really a program that helps to have these conversations. What I tell patients all the time is, I come from the palliative care perspective doing symptom management, pain control, shortness of breath control, but also to talk about the what ifs and set goals of care. I think it's really important for everybody that they determine what their quality of life is. So we all have a measure of quality life. So for example, mine is if I can't talk to my family in a rational way, then I don't want a lot of aggressive care. And I had this conversation with my wife just recently about those issues. We all have our own level of quality of life. I have some patients that said do everything. Other patients say do nothing. And if we can define that goal of quality of life or that quality of life, then we can make all decisions that are rational. If we do that during the day, then we can actually make logical decision making for that patient.
So in developing this care plan, how important is it to allow people to change their mind?
I think it's always important. People can always change their mind. I think as we develop these plans during our lifetime, which is start honestly in your early 20s, because what happens in your 20s, you're at higher risk for accidents. So car accidents, that type of stuff. Right. So what happens if you have a car accident? But as you go through your life, change that care plan over and over. As you get into your 50s, it changes once again. When you get into your 80s, it changes again. And so you may want to be aggressively treated when you're younger, but not so aggressively when you're older, and having good conversation. I think the key is having conversations. We actually are doing a project at Samaritan called Timely Conversations.
Right.
And it's really important that we get everybody in our community talking about that. We're really having people want to think about what they really want at the end of life, really talk with their family about that, and then to act on those conversations. So it's important that you then write it down too, because you can talk all you want, but unless you develop an advanced care plan, advanced directive, or a pulse form, nobody really knows what your wishes actually are.
The pulse forms are all across the country or just in various states?
They're in various states right now. There is a movement to get them nationwide. And you'll hear pulse, you'll hear something called MULS, which is in Colorado. So they have a little bit of a different terminology, but they're really a form that says, these are my wishes, and it's actually a physician order.
Right.
So what happens is that if you are in a mall somewhere and you drop over and you have your pulse form on you, they won't bring you back if that was your wish. So it allows them to actually honor your wishes at that point in time.
The issue of keeling over at the mall, though, is how does somebody know that you have that?
That's always the hard issue, and it really is difficult. Certainly at home, we encourage people to have them on their refrigerators, have them in their glove compartment boxes. But in the public, it's a little more difficult.
Am I correct also, because I think I bumped into this in doing some work in this area, that there are now apps on the phone that you can download all these forms?
They're beginning to. We've worked with a couple companies that are doing them electronically, so you actually can electronically put your wishes node in a central area. So I think as we develop our smartphone technology, that will certainly happen for us.
So two quick things before we start running out of time. Just talk a little bit more about the power and importance of palliative care and the myth that palliative care is only for those last days of life. It's really much more expansive than that, correct?
So I think with palliative care, what's really important is that we get involved really at diagnosis of life-threatening illness. There have been many studies now that have shown that palliative care programs and physicians actually extend life. So if you're getting cancer treatment, you actually live longer when a palliative care physician is involved. And I think that's really important. And it makes sense because what palliative care does is helps to manage symptoms. So if you're having a lot of pain during your treatment, you don't go to treatment. If we can manage that pain, then you can go to more treatment. It also then is available for conversations about what the goals are for that. And so that can extend, the conversations. A lot of patients get treatments at the very end of their life that are not wanted or actually cause more harm than good. If you can prevent those interventions, then you can actually extend life that way. So for me, palliative care is a collaborative treatment plan along with your aggressive treatment plan too. So you get both things going at one time. Best of both worlds. You get aggressive treatment and you get your symptoms managed and you get conversations happening.
So I have to ask you this as the Chief Medical Officer of Samaritan Healthcare and Hospice. The demographics of our country are changing. As a rabbi, I'm also concerned about the spiritual component of working with, and I know you have chaplains on staff, and I know several colleagues of mine who are chaplains at hospices around the country. Could you talk to us a little bit about how you're beginning to deal with not only the spiritual component of families who come from all different religious backgrounds, but also the cultural, ethnic diversity of the United States? How do you and your cohorts beginning to deal with this?
So I think what we learned in communication specifically, you can't communicate if you don't understand the culture. My background actually is in anthropology, so I come from a very culturally based training. It's really identifying what the culture is, what the ethnicity is, and then how do we deal with that particular person and their family. Samaritans are very proud because we now have a cultural diversity program going on. We're learning about our friends, our colleagues in the community. We're learning about our Jewish hospice program, our Catholic hospice program. We're actually learning about our Muslim and our Hindu population, just trying to understand our education so we can then help that family and trying to tailor our program to them. I think that's really important because if you don't meet the patient's needs and meet the patient where they are, then you miss so much in the care for that patient.
So I know you're involved with Sukkot Shalom, the development of a Jewish hospice program for Samaritan. I know similar types of programs exist around the country. How important, in your experience, is that role of faith and spirituality in this process?
I think it's extremely important. I think that, again, with hospice care, palliative care, the medicine is the easy part of this. It really is that spirituality. It's the social part of it. It's the counseling. If you miss that component, then you've missed, I think, a majority of care for these patients. Most patients, you can manage their pain or their symptoms very easily with medication, but it's that suffering that you want to get to, and suffering is what we're focusing on. I think that is where that spirituality. So if we can support that spirituality with our chaplain help, getting them connected back to their faith-based community, and addressing it, I think it's really very important.
That's interesting. You say that the medicine is the easier part. The soul is the more challenging part.
Absolutely.
So that's a very, very good way to end this. Dr. Goldfine, thank you very much. Dr. Stephen Goldfine, the Chief Medical Officer of Samaritan Healthcare and Hospice located here in Southern New Jersey. I want to thank you for joining us, and to all of you on behalf of Jewish Sacred Aging, thank you very much. Check us out on our website, www.jewishsacredaging.com. Till next time, shalom.